Hello, and welcome to LCTV's Breast Cancer Awareness Week. I'm Larry Seidling, your host, and today I have some special guests. We have breast cancer navigators, along with a radiologist from Miles Health. First up, I would like to have the breast care navigators introduce themselves, or our panel introduce themselves, and we'll start with Melissa.
Hi, I'm Melissa Lewandowski, and I've been here at Lincoln Health Miles campus for about 14 years. I am a breast imaging navigator, and I work in mammography as well for about 10 years.
And my next is Kelly.
Hello, my name's Kelly Brackley, and I'm a breast imaging navigator as well. I've worked at Miles for the past probably 14 years almost, and I'm a mammographer, and I've worked in mammography for about the last 13 years.
And my next is radiologist Dr. Charles Mullen.
I'm Dr. Charles Mullen. I've been with Spectrum Medical Group and Lincoln Health now about 22 years.
My goodness, that's a lot of longevity between the three of you. Okay, my first question is, so what is a breast care navigator? And I'll let either of you flip a coin.
I can start with that. Maybe the easiest way to explain it is by maybe giving a little bit of history about breast navigation and how it came about. It was probably back in the mid-'80s that there was a doctor named Harold P. Freeman, I believe, who was noticing that a lot of his breast cancer patients were coming to him, and he was seeing basically a racial disparity. Patients, black women in particular, were coming with more advanced cancers. And when he started delving into the reasons why, they were finding that black women had less education about screening mammograms. They were less educated about how to determine breast cancers. And so he started using navigators in his practice. And once they started looking at the data, they realized that it greatly reduced mortality rates and the diagnosis in that particular demographic. So as navigators, we look at basically leveling the playing field for all individuals who come to us with an issue. There's navigation along a whole spectrum of the breast cancer spectrum, from basically starting from the education piece at the doctor's office to end of life. We basically focused on the imaging aspect of that, from when women are educated about screening mammograms and when they come to see us for screening mammograms and any diagnostic workups that they may need. So we facilitate that process, and if a woman does have a diagnosis or any type of additional imaging that's needed, we help navigate them through that system, and navigation has been shown to definitely help the prognosis of any type of diagnosis.
So
I'm sorry, go ahead.
So when we're sitting down with them, we're basically trying to figure out what their barriers are, what their support system is, what their finances are, what their transportation is like, and help them find resources to help them get through the whole process. And basically, we're starting, like Kelly said, from the imaging aspect, and then at the diagnosis aspect, if they are diagnosed with cancer, they sort of get handed off to oncology navigators who take them through that aspect.
This one's for Dr. Mullen. Everybody's heard the word breast cancer or cancer, but exactly what is breast cancer?
Breast cancer, like other cancers, is the situation where you have cells that kind of lose their ability to regulate their growth. They can't limit their growth and grow beyond what they should grow, and grow in fact into tumors. In the breast, there's a couple main types of breast cancer, and then there's a few more unusual types.
I'll throw this one out for any three of you. What is the very first step a person should take if they find a lump?
Call their doctor. You can, you can look at a lump, and if you have it initially but it goes away, you should keep an eye on it you don't have to call your doctor immediately for every lump, because the majority of lumps are not necessarily cancer, but keep an eye on it. If it stays, if it persists, if it changes, then at that point you should contact your doctor to have some sort of imaging procedure to see what it is.
Are there any other symptoms that may come forth after you find a lump, or is it painful, or?
I think most people initially feel like the main symptom that you're going to find is a lump. Keep in mind, though, too, if you're feeling a lump, it's probably already advanced to a stage that would need a little bit more intervention than something that was found on a screening mammogram.
If it's a cancerous lump.
If it's a cancerous lump. Because like Melissa said, there are plenty of lumps that people have in their breast that aren't cancerous. Some other symptoms that may be noted are a dimple in your skin. Sometimes women can have what's called peau d'orange. It's like a thickening of the skin. It almost looks like an orange peel. Pain does not usually present itself as something that is indicative of breast cancer, but it can as well be a symptom of it. An inverted nipple is also.
Or a discharge from your nipple, or a retracted nipple.
It's important to keep in mind, though, that many breast cancers, the idea of screening is to find them before there's any symptoms at all, before they're even palpable by a trained doctor or clinician, and really that's the whole purpose of screening, is to find them early before they've even advanced to a state where you can feel them or have other symptoms.
Most masses seen on a mammogram in most breast lumps, they turn out to be not cancerous?
Generally speaking, yes. Very often, we'll have women come in very, very anxious, and in fact, they'll have a very benign finding. We'll work them up and find they just have a cyst or some other kind of benign finding that doesn't have any additional risk for cancer.
But sometimes the benign findings do have additional risks for cancer, and we'll take them out. The patient will have them taken out anyway, right?
And sometimes it's indeterminate. If it is something benign that's, say, large and kind of annoying the patient, perhaps they kind of just feel it and it's distracting. In that case, benign findings we may have a surgeon take out as well.
There's really no age limit for when breast cancer can strike, is there? All ages are susceptible?
There really isn't any age limits. We screen regularly women 40 and over, but we have in fact had patients diagnosed earlier than that as well. So
it is extremely rare below, say, 30. But yes.
Below the age of 30?
Below the age of 30, it's extremely rare. But
your chances of breast cancer increase as you age. We have so many patients that will come in and they have no family history. They don't think that they have to come because they've reached the age where they don't have to come anymore. But the biggest risk factor for developing breast cancer is being a female and getting older.
How many new cases of breast cancer are projected in the U.S.? It's amazingly different, the number between female and male, but males are susceptible to it.
Mm-hmm.
Correct.
Yes, we do see male patients, and we do mammograms on men as well when they have some kind of abnormal finding. Usually that's since we don't do screening on men, it's generally some kind of either palpable finding that they can feel in their breast, or sometimes in the case of pain, they'll come to see us, and we'll also do men.
So a man has the same symptoms basically as a female. Male could have a lump?
Yes.
What's the trends in mortality rates showing? It's a big leading cause of death here in the United States, or the world for that matter. What do you see as opposed to the lung cancer? How does breast cancer rank up?
So, behind lung cancer, which is the #1 leading cause of cancer death for women, breast cancer is right behind that. And the chance that you're going to die, a female is going to die from breast cancer, is about 1 in 38. But our mortality rates have continued to decline because of earlier detection and earlier treatment.
We did a show earlier this week with a couple of ladies from the American Cancer Society, and they were talking about research and development and how that has really brought cancer to the forefront. What's your feelings towards that? True?
It definitely has. Yeah, yeah, true.
What is the risk of being diagnosed with breast cancer? That's a good one.
So, over your lifetime, about 1 in 8 women are going to be diagnosed with breast cancer. And, you know, there's no way to prevent being diagnosed with breast cancer, but there are certain risks that we take in our lifetime that increase our chances of being diagnosed with breast cancer, which could be like the lifestyle risks include alcohol, obesity, physical inactivity is one, and not having children and not breastfeeding are lifestyle risks that increase your chances of having breast cancer. There's certain inherent risks of being diagnosed with breast cancer as well that we can't change, such as being a female and getting older, inherent genetic mutations, family history, personal history, race, and ethnicity are all inherent risks for being diagnosed with breast cancer as well.
It should be emphasized, too, that as many women who do get breast cancer, most women are cured. Really only a small percentage.
It's a high success rate, isn't it?
Yeah, it really is. It's, you know, as high as the incidence of breast cancer is, the mortality is only about 3% of causes of death in women. Whereas in fact,
For full disclosure, my wife had breast cancer, and she's a survivor, so
Right, yeah.
I'm somewhat familiar with the whole process. Dr. Mullen, can you go through what a radiologist, what part does your play in from the time a lump is found in a woman,
sure. Well,
or in a patient, I should say?
when they come to our department, generally we start with a mammogram first. In rare cases, younger patients, occasionally we'll start with an ultrasound. But generally we start with a mammogram, and we'll examine that. I'll review that, evaluate whether it's something, whether we see something definite, whether I don't see anything on the mammogram, but I'm still concerned. Then we take additional steps if there is some further concern. Oftentimes we'll get an ultrasound. Ultrasound is very helpful in focusing in on a particular finding. We can better characterize things as to whether they're more suspicious or less suspicious on ultrasound sometimes than we can with mammogram. And then, so that gives us additional information as to whether the patient needs to go on and actually get a piece of that tissue, do a biopsy, and evaluate it more thoroughly. Very often, again, a patient will come in with a lump, we'll do a mammogram, then we'll go on to an ultrasound, maybe find that it's just a simple cyst, which is a benign finding that we don't really need to do anything for. We could put them back on their annual screening schedule. But if it's something that's more concerning, a more solid-looking lesion, particular characteristics make me more suspicious that it is cancer. In that case, we'll end up referring the patient to a surgeon and oftentimes going on to do a biopsy. Many times the biopsies are done by myself in the department with the breast care team, as well as our sonographers. And we'll use a needle biopsy and get the tissue required to make the diagnosis by the pathologist.
It's really nice.
After that, I should say, if it does come back positive, very often the next step will go to be a surgeon, and they'll often go on to have a lumpectomy.
Like Dr. Mullen said, if they can see it on ultrasound, it's really a great option in the community to be able to have it be done locally. So if he can see it on the ultrasound, he does the majority of our ultrasound-guided biopsies here, so patients don't have to travel very far. If they needed another type of biopsy, which is a stereotactic biopsy, we do have to send them to Scarborough for that because we don't have the equipment. But we are kind of looking into that to see if it's something feasible that we could offer at Miles, which again, we have an older community here, and not everybody wants to travel to Portland or Scarborough. So if we can keep all of these treatment options or biopsies local, it's really beneficial for the people that come here.
Okay, how often should a woman or a patient, I guess add, because men do get breast cancer, how often should they have a mammogram? Is it yearly or bi-yearly?
So there are a whole bunch of organizations out there that do put out recommendations for screening mammograms. There's the American College of Radiology, the American Cancer Society, I think is one of the most common ones that most people are familiar with. And there's the Congress of Obstetrics and Gynecology. There's the U.S. Preventative Task Force. We typically go by the American Cancer Society recommendations or the American College of Radiology because they are our accrediting institution. The American Cancer Society, basically all recommendations state that a woman should, by the age of 40, have a baseline mammogram. If you have a first-degree relative that has been diagnosed with breast cancer, that would be a mother, a sister, they would really recommend that you start getting a screening mammogram about 10 years before what their diagnosis date was. So if you had a mom who had had breast cancer at the age of 45, we would recommend that you start screening at 35. You know, everyone has a different comfort level about when they want to come for a mammogram. Some women are adamant that they are going to come every year for their annual screening. There's a lot of other women who feel that, you know, every 2 years is okay. Everyone has a different comfort level with that. The American Cancer Society does recommend that women remain on a yearly screening schedule between 45 and 55, and that after 55, if you've had no family history, if it's something you're comfortable with, you don't have any extenuating risk factors, that it is okay to go every 2 years. That being said, I think we all procrastinate a little bit about having a mammogram. It's not something anybody really looks forward to having, and I think you know, most women try to avoid it if they can. We see a lot of women who, you know, like Melissa had said earlier, you know, make the statement that I don't have any family history of breast cancer, or I've never had a negative mammogram, or, you know, that type of feeling. And the reality is we diagnose more breast cancers in women that have no family history.
What are some of the common misconceptions about mammograms?
Well, I think one of the common ones are that men don't get mammograms. You know, when, like Dr. Mullen and Melissa had said earlier, we have men who come to see us on a regular basis. Men will have lumps too, and we usually see them for diagnostic appointments. We don't screen men, of course, for breast cancer. It really just isn't feasible.
It's not a feasible option, just because it's so rare in men.
Right.
I think one misconception too is that, you know, that it has to be a painful experience, and you know, I take a lot of pride here in that our mammographers really know how to accommodate patients and engage the level of discomfort. You know, there can be various reasons why one woman's breast might be more sensitive than another's, and while we do compress the breast, we do a mammogram. There's, you know, if a woman's breast is more sensitive than another woman's, we might not compress as much. We're trying to keep everybody in a zone of comfort that's allowable to them. So, you know, you do hear a lot of women talking about, you know, how much their mammogram hurt. Well, if that was the case, then you know,
your imaging person was not really, you know, in tune with you. And I think that, you know, we don't spend a ton of time with our patients, but I think when the patients come in, we really want to have a connection with them. We want to gauge what their anxiety level is about the mammo as well. And you really should, as a mammographer, you should be able to read their cues. And you tell them, you know, let me know how this feels. Am I hurting you? And you really only go as far as necessary for the exam, which is to kind of, you know, spread the tissue out, but also to hold the breast in place. But you do want to get a good image, but you do not want the patient to never come back. And I tell patients frequently, you know, they'll come in and they'll say, I had the worst mammo, and, you know, it's been 10 years, and this is why I haven't come back. And I frequently tell them, you know, technology is always advancing and changing, and I do think that mammos have become less uncomfortable in the past, but it's the worst thing that you can tell somebody that you love, that it was the worst experience of your life, because if you tell them that, then they're not going to come in. And, what is maybe a bad experience for one person is not necessarily the same for another. And I would like to think, like I said, as mammographers, we really do take the time with our patients to make it as pleasant of an experience as we possibly can.
With COVID-19, what changes have you noticed related to mammograms? What has Lincoln Health how have you had to adapt?
Well, I think actually I had a patient this morning who came in and said, it's so quiet around here. And believe me, we don't feel that it's quiet ourselves. We feel very busy. So I think, it just goes to show the community as they're coming in that we really are taking really good steps to keep people socially distant, keep our waiting rooms emptier, and a lot of the protocols that we've put in place have really helped, keep the patient flow very constant and steady. So our waiting rooms are empty.
We've taken those steps, by having patients register when when they're in the car, they register using their cell phone, they call up, and then they have to go through the front entrance. I think by the time, taking these steps is really to be cautious, but by the time they get down to mammo, I think they've been kind of through the gauntlet a bit to just get through the door. And I have so many patients right now that tell me that the mammo is the easy part of their whole day, really. So that feels pretty good, that it's the easy part now.
Well, this has been great. We've covered a lot of territory, a little quicker than I thought we would have. One final question. What has Lincoln Health done to make the patients feel more comfortable in this time of the pandemic?
Well, I think they've certainly done things to decrease the traffic flow and just we've successfully, I think, avoided situations where we have a lot of patients in close proximity to each other. As you've heard, people are basically staying in their cars until it's time for them to come into their appointment. So our waiting rooms are pretty empty. And I think that's probably the biggest safety feature that we've enacted since COVID started.
Well, I'd like to thank you, Melissa Landowski, Kelly Brackley, and Dr. Charles Mullen for sitting in for this half-hour talk on breast cancer awareness and mammograms and the whole terrible disease that is out there. So for LCTV, we want to thank you. And for folks at home, we ask you to join us again tomorrow night as we have another in our series of breast cancer awareness. And we thank you for watching LCTV, and we'll see you tomorrow night.